welcome back to the Middling Along podcast. I'm your host, Emma Thomas, and today I'm delighted to welcome along Dr Angela Wright. She's a GP, menopause specialist with Spiced Pear Health and clinical sexologist. She's also qualified in palliative medicine and worked in hospice medicine for over a decade. She is particularly interested in improving sexual function and menopausal symptoms in women who have undergone cancer treatment. Angela's passionate about women's health and sexology and is frequently asked to teach or talk about this subject. She's also involved in training future menopause specialists and part of the faculty for the sexology course that she trained on. She's an active committee member of the British Society of Sexual Medicine and the Education Committee of the Primary Care Women's Health Forum. Welcome to the podcast, Angela.
Hello, thank you for having me.
So there's perhaps a sort of a trope, I guess, that's been around for so long, that part of that menopausal transition is that sort of our ovaries dry up and stop working, and at the same time we sort of all our libido kind of leaves the building. We might just totally lose interest in sex and in a relationship, and it's kind of the beginning of the end. But it doesn't have to be like that, does it?
No, I was just thinking as you were saying that actually that isn't always what happens when I probably see the people in my clinic who are struggling with it more, but often by the end of the journey, things are, they're back on track again, and I get women who find that they're having good, better sex at this time too. So it can be different for everyone.
So what are the types of things that you typically see people? Is it the sort of loss of libido? Is it sort of painful sex? Is it kind of any kind of combination of things that you see?
Yeah, I mean it's all of that. I suppose the thing that I get sent the most is loss of libido, but it doesn't mean that that's actually what's going on. I think I always say that, we do the stuff that we enjoy, and if sex has become joyless or painful, or you get an infection, or you feel rubbish about yourself when you look at your body or whatever, naturally you're not that bothered about doing it. So sometimes when you ask people about what's going on, it's not loss of libido, it's pain. Or, so I get painful sex, I get people that feel that arousal isn't as sensitive, or it's even painful, so that it's just difficult to get aroused or difficult to climax, or there might be some pain. And then there's that sort of loss of desire. They're probably the main things that I come across, really. And
obviously anything to do with sex is kind of multifactorial, and actually maybe you explain what multifactorial means, because it's a slightly technical term. So if when we talk about that, what does that actually mean?
So my training, so I'm trained in psychosexual therapy, I'm trained in sexual medicine, like 2 separate courses. But the framework that I was taught to look at it all through is called a biopsychosocial lens. And I always say it's like a Venn diagram. It's like 3 overlapping circles. You've got what's happening in your body. Obviously at menopause, there's loads of stuff that's happening, especially if it's, if it's surgical or cancer induced or something else has caused the menopause. It's even more complex. You've got what's happening in your psychology, in your brain, in your identity, and how you feel about yourself and your sexual self. And then there's what's happening in your world, say within your relationship, or your sense of yourself and who you are from the outside world. And all of that stuff can have a huge impact. And it is, I think everyone sort of looks to the hormones as being the tipping point, or maybe the obvious thing that happens at menopause. But, I know you'll know there's so much other stuff that kind of is part of that identity transition that goes on as well at the same stage, and that all impacts.
We'll maybe start with vaginal estrogen, because I think there's perhaps, again, we know that there are sort of myths and misconceptions about kind of systemic HRT. So maybe, in terms of if people are sort of struggling with libido, with issues kind of in the genital area, that are kind of soreness or dryness or that kind of thing, how much can, if someone's looking at HRT, how much can that help versus how sort of localized vaginal estrogen helps? Are they doing sort of different things? Do we need to sort of start and try one before we try another? How do those two interact?
It's pretty individual, to be honest, because there's different components to your sexual response. Your brain's like a volume switch. So if your brain is primed with hormones, that's part of what makes us think about sex and respond to sexual thoughts and have fantasies and stuff. So for some people, when they've gone into menopause, they genuinely, I have women that just say, I just don't understand why I wanted sex before. I look at my partner and there's just nothing. And,
So I'd rather have a cup of tea.
and exactly. And it's like, I just don't understand, what made me want to do this before. And obviously you want to maximize the touch that somebody can receive and the sensation and how aroused you feel, and all of that stuff you do with local estrogen to a large extent. That's going to change the tissues, make them stretchy, help the nerves to be dense and responsive, and help you to lubricate and not have pain and not get infections. So the local stuff's really important, but the systemic stuff helps your brain. If you need help, it helps you to get more blood to your breasts and back into your pelvis. So there's lots of people for whom it's not just about the genitals, like they've lost nipple sensation. It doesn't feel good when somebody caresses bits of them or they caress themselves. It doesn't feel the same. So I feel it's kind of artisan is what I feel it is. You've got to really listen to what's happened. And then for some people, giving them the systemic HRT will give them enough estrogen that it sorts out the genital problems. But for my personal view, is we don't ask women enough questions about the quality of sex. We just say, is it painful? Are you dry? Can you climax? But when you actually ask, is it as sensitive as it was? Does it take you longer to climax? Do you feel like, the sensation, do you feel less aroused, less engorged than you did? And you pay attention to that, you'd probably give more people vaginal estrogen, because I think we slide down and we only know that stuff is bad when something happens that's bad as a result of it, if you know what I mean. So I offer my women both. I offer almost everybody both systemic and local, if they're okay to have hormones, if they want them, and if that's the approach they want to take.
And presumably, and correct me if I'm wrong, but if you're going to see your local GP to talk about sort of HR, whether to sort of start taking HRT or not, they perhaps won't understand all of the nuance that you have just explained.
No, and I think, and I have to say, like, before I was trained, I wouldn't have done any different. I don't, it's not the GP's fault. We're not trained about it. We don't talk about sex beyond Viagra, STIs, stuff like that. So, and I do think that sometimes when people get my my care plans or my letters, whether I'm in the NHS or whether I'm sat in a private clinic I do the same thing in both, really. I think sometimes the GPs raise their eyebrows and they're kind of, oh, why do we need both? And why is she giving so much? And if you're giving vaginal estrogen, it's barely absorbed systemically. There's studies that say that if you use it and you look at the blood tests of women who have it, it's barely perceptible, the amount that goes in after the first couple of weeks. So it doesn't, for most women who are low risk, it really doesn't add anything to the picture of risk in having it. So I tend to sort of be proactive, and because I don't think we're not very sex positive as a society, and we're not very sex positive for women. We don't encourage women to aim high. So I think it helps to be informed. There's really good guidelines I direct people to. So the British Society for Sexual Medicine have done a consensus statement on genitourinary syndrome of menopause, and it's available to anybody on the BSSM website, and it's on the Balance website as well, because we had some input from Louise Newson's team, and that is evidence-based. There's all the information is on there, and that helps to underpin the practice.
So that's somebody
useful.
could take that along, to print it off, take it to a GP
Absolutely.
appointment.
And it's endorsed by the BSSM, so it's kind of endorsed by a society that is respected and known for sexual medicine. So I think I often tell my patients, print that off, take it to the GP. That will help them to understand the evidence base for what we're suggesting. And that's something you can do if you're listening and you want to be more proactive.
Great. Well, let's make sure we get that in the show notes.
Yeah,
but
absolutely.
I want to pick up what you were talking about the sort of the risk element, because obviously for somebody who's been through breast cancer and has estrogen receptive breast cancer, they potentially not able to take systemic HRT, but they could have localized estrogen.
Increasingly, we understand that is not associated with risk of recurrence getting any bigger. So certainly for women who are on, so people with breast cancer, some of them have had hormone receptor positivity, some won't. So those that haven't had positive hormone receptors don't really need to worry about it, any more than anybody else does for the cancer that they've had. But women who've got hormone receptor positive cancer would always be a little bit nervous about the idea of somebody giving them any kind of estrogen. And there's decent levels of research evidence over a number of years that show that there's no increase in recurrence risk, and we're getting more papers that help to support that for letrozole users as well as for tamoxifen. At one point we thought tamoxifen, it was all fine, but for women who were on aromatase inhibitors, which work slightly differently, that maybe we needed to be more cautious. But there's some guidelines that came out from the American College of Obs and Gynae that helped to support the use, and there was a big study. I can share these guidelines in the show notes. And there's a big study last year in November that was in the Lancet, I think it was again, which was also really encouraging and showing no signs of adverse outcomes for women who use those. And it's because so little is absorbed. You're putting something on that is very, very minimally going into the system. When we measure estrogen levels, we're normally somewhere between 2 and 600 when we're treating someone with HRT systemically. And the most that they've shown that it goes up in the studies with vaginal estrogens is kind of like 5 or 6, so wow. It's tiny amounts.
And it's not like systemic HRT where it's so for example that's like the oral types that are processed by the liver, and
exactly. It's just
only acting on that sort of area where it's being applied or
where it's applied. And also I think it's valid also to talk about the fact that people have very individual feelings about risk, so I speak to some women who absolutely wouldn't touch it with a barge pole. They're really frightened, they don't want to touch any estrogens, and that's valid. I speak to others who are quite keen, but their oncologist is very cautious for them. And that's more difficult because actually they may really value the sexual function and what that gives them. And I get lots of women referred to me, and often a lot who'll come and see me privately because they want to talk to somebody who understands the value of their sex life for them. And because I think we do that instinctively with men with erectile dysfunction after cancer. We instinctively get that it's important to try and do something about their erection, but we don't really have that same attitude for women after breast and gynae cancer. It's much more of a lube will probably allow you to have penetration. It's going to be fine. You probably don't need estrogen. But I think that's attitudinal. I think that sort of is that we're not, if women get erectile dysfunction in their clitoral tissue, we don't see it. You can't, women have joyous sex and it doesn't necessarily have to be discussed if they don't want to do it. They can internalize that and kind of, put up with that. And I do think that attitude kind of informs the norms a little bit. So I think it's important my view is it's important to let the woman choose how important this is for her. And it's not always just about sex. Sometimes it's about urinary tract infections, or I've had a woman who's given up horse riding because she couldn't sit on a saddle without the discomfort of GSM, or wearing jeans because the seam is too uncomfortable. So I think it gets underplayed in terms of the quality of life element of it versus the risk, which is absolutely minuscule.
And I think certainly from the sort of the statistics that I've seen before, if you compare the number of people who potentially are struggling with those GSM type symptoms and the percentage of people that actually go and seek help, there's this huge disparity where either people are, it's just too embarrassed, they feel too embarrassed, they feel like there aren't any options available to them potentially because they don't know what's out there. Or maybe, worst case scenario, I guess, is that they go to their GP and they're just fobbed off.
It's almost like I'm maybe being a bit too apologetic. Most of the doctors that I know intend to be patient-centered and intend to care. But I just think there's a prevailing kind of, it's almost like a benign neglect. We're just not encouraged to think about it. We're not really told how bad GSM can be. We're not really taught what that may feel like. So if you've never experienced it, you may not have any real concept of quite what that does to your sense of self and your sexual function and, the risk of UTIs and things afterwards. Whereas I think there is, if we think about similar sexual dysfunction in guys, we kind of understand a bit more that might be quite a big part of their identity gone if they can't get an erection and they can't, So I think it's just not
physically visible,
thought
isn't
of.
it? If there's something kind of
It's visible, and
something
we have
wrong or uncomfortable or red
exactly.
or
And the
sore.
amount of consensual miserable sex I hear women having is surprising. Lots of women will put up with joyless sex at the very sort of minimum. As far as I've had women who bleed each time they have sex or have an infection each time they have sex, and they still will have it because that's what they think is important to protect their relationship, to look after their partner. It's really complicated, isn't it, the role of sex in our lives and in our relationships. So I just think that it's important to sort of validate that it can feel really important. It can feel really devastating to be without it. And I definitely hear that in clinic from women who've been told that, they shouldn't have estrogen because they've had an estrogen receptor positive cancer. And we're just talking about vaginal estrogen here. And they've still come across barriers for that because it's not really been understood what that takes from them, what how they might. I've got a patient that I saw when I was working at Maggie's. He wasn't being allowed to have vaginal estrogen, and yet she was allowed to skydive. And I always think that's a really good example, do you know, of like how we can be a little bit paternalistic in my profession sometimes.
Yeah.
It's just ridiculous, isn't it? I mean, she could smoke, she could drink a bottle of whiskey a night. No one's going to stop her doing that. But we will say, no, you can't have vaginal estrogen.
Wow. Let's move on, because I think there are huge sort of swathes now of femtech, sex tech, who are kind of waking up to menopause as a quite a lucrative market. It's going to be a billion of us out there by 2025, which is only next year now. Maybe let's have a chat about laser therapy, because I think, again, that's something that's increasing in popularity. Where do you stand on that?
So I should stand where the evidence stands, which is that, and there's not that much of it, not that much research evidence, but we're getting more of it. And tentatively, it's positive, but I would say tentatively in the sense that we have more good evidence that says that simple things like vaginal estrogens do the job better. We know more about them. And like I said before, for most people, that is an option, even if it's not being put in front of them. The women that might be the group that go for laser probably would be fine to have estrogen if they were having a conversation with somebody who understood the evidence properly. But for those that want to have it, and it's often expensive, I suppose my reservation around it is it's expensive. It's not, we don't know much about the long-term impacts of it, but we do know that the short-term impacts appear to improve, collagen in the tissues and the strength of the tissues, and decrease discomfort. And for things like stress, urinary incontinence, there's some benefits from things like laser and radio frequency for things like that. So there's some tentative signs that this is something that could work quite well. But I suppose my comment is most of the women who would be in the cohort who think that that's the choice they need to make could probably access something that's got more proof that it works, and it's going to cost them very little. So I would sit there and say, that's where it sits for me.
What else have you seen sort of in terms of sort of sex tech that's new and interesting versus kind of maybe just a kind of a gimmick? Or
so I think it's like anything else, isn't it? Sex is really individual, right? So our own sort of sense of what we like, what we don't like, who we want to have sex with, how often we want to have it, which bits of us we involve in that is very, very different. So I'd never want to say to somebody what will and won't add to what they do. You're absolutely right. People can see the menopause money here and can see the pounds that they can make with it. And it's like, I'm giving you the background, I suppose, that the way that I was taught to think about sexual response and pleasure is like it's an accelerators and breaks things. So the more that you can step on an accelerator, the more sexual arousal you get, presumably the more pleasure you get and the more chance you have of raising your libido because you had a good time. So toys potentially can step on that accelerator, intensify sensation where you may not have very good sensation because your tissues may not have the same hormones and the same blood supply into them. So they can play a really good role in increasing sensation. And then within sex tech, there's a lot of new stuff that's emerging. So when I went to the annual conference of the European Society for Sexual Medicine in when was that? Maybe February of this year. It's like it was recent, but I've forgotten when it was. And there was a lecture about sex tech. And they were looking at some of the sex apps and had studied the sex apps to see were they evidence-based? Did they seem to be useful? What was the content? Where was it derived from? And does it improve sexual satisfaction scores? And there's evidence that they do. They kind of educate. So things like Furly and MJoy, those apps that have got sex therapist content, they tell you about how your body works. They bust a load of myths that tend to tie us down. And they give mindfulness and maybe guided meditations and techniques and so on. OMG Yes would be another example of where the internet is actually really helpful for women. There's the Pleasure Project and all sorts of bits and pieces. So there's that kind of stuff to increase knowledge, and if you have better knowledge, you try new things and you can do better. There's toys that are, there's heated toys, there's toys that connect to apps and can track your how your orgasm
is to me. I mean, I've got a heated blanket, but
well, and I guess my argument is, and it is an argument, I accidentally got into a social media argument about this, not really meaning to, but just kind of because it was being marketed as equivalent to or a valid choice other than HRT to choose orgasm as a choice to manage your menopause in a kind of, orgasm releases these chemicals, HRT gives you these chemicals, choose orgasm. And I was a bit like, well, actually, it's not a choice for everybody. B, not everyone can do it. C, what about trauma? All these things, surgery. But in reality, if you have some warmth and you increase the blood flow to an area that needs to be engorged, it's probably going to be useful to do that. So it's not that those things won't work. I just think you've got to be kind of, it's not going to work if you've had your nerves cut because you've had a hysterectomy or because you've had radiotherapy and you're scarred, or your brain's like, it's got to be in context with everything else, hasn't it? There's the Lioness that's available, I think, in the US, but it's probably going to come here, which will tell you what your orgasm's like. The Lioness, I think, tells you, whether you've had a sort of crescendo orgasm or a sort of multiple waves orgasm, and I guess if you're rehabbing after, surgery, or if you're working on your pelvic floor muscles or you're using estrogens and you want to get some feedback, you can see how that might be useful. But I guess like anything, you don't want to feel like you're failing at your orgasm or looking at your data and kind of going, oh. So
I got a 6.
yeah, I was going to say, I'm not sure that that's going to suit everybody. And there's a lot of different tech in terms of, I mean, I get a lot of women to move to suction and air technology as they get older, which is pretty well known now, I think. I don't think it's that unusual to know about clitoral suckers and air tech rather than vibrators, but usually male and female bodies, the sense of vibration sensitivity gets lower as you get older. So it can be harder to, a vibrator might work too well for you in your teens and 20s because you can't quite slow yourself down enough, or it's a bit too much. But by the time you're at the other end of the sort of fertile life, it might be that it's not quite enough anymore. So vibrators are quite good as a tool to look after the tissue. I get people to massage with a vibrator turned down low and there's studies that show that improves blood supply to tissues and it helps them to be supple. And so your breast cancer patient that's got dryness and soreness and is only using a tiny bit of estrogen, a vibrator turned down to its lowest setting with a bit of an emollient for a minute morning and night can be great to get a bit of subtlety and stretch and flexibility back in the tissues again. So you can use them in that way, or to soften tight muscles if you get pain and you get vaginismus. Vaginismus is where the pelvic floor muscles get really tight as a reflex, and sometimes you can use toys to help with that, to soften those muscles off. So we use them kind of therapeutically. But the suckers can be good if you can't climax. The Eros device was the original one that helped women who were struggling to climax by pulling blood into the clitoral tissue. They sort of puff, 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 suck, suck, suck blood. And it's not very high quality evidence, but there is some research evidence that shows that might improve sexual response even when you're not using the toy. So it might have some longer lasting benefit, but it's not high quality evidence, but it would make sense.
So, I mean, I guess is very sort of individualized, but is that something that you would sort of generally sort of suggest to somebody once a week or a couple of times a week, or?
I mean, I tend to get, it depends what someone's come with, but if it's a pain, vaginismus, skin's uncomfortable with GSM, post-cancer kind of picture, I routinely tell patients to get into a self-care regime and just say, look, wash with an emollient. I tend to suggest it's okay to use things like sweet almond oil and coconut oil. I know that some people don't like that, but lots of us who work in sex med use it. A, because it doesn't smell medical, it's quite sensual, it's nicer to use that than to have another medical product. But the vulval dermatologists that I've worked with support that. It's very inert, it doesn't create irritation or dermatitis, and if it's used externally, it's fine. But some people are worried about thrush and, would want to avoid that and would use an emollient like Epiderm or, E45 or whatever, aqueous cream. But using something like that to wash with, and then massaging externally over the labia, over the clitoris. Like, you've got to be so careful with the clitoris because the hood of the clitoris, it's a bit like foreskin in men. And it needs to be retracted and cleaned underneath, and none of us are taught that. And as you get into menopause, it's quite, you can get phimosis, so you can get adhesions, it can get stuck. And it can become painful when it's engorged, or I get women where it's almost buried because of skin changes. So that bit of self-care of washing, moisturizing, just lubricating, like moving those tissues, making sure that they all still move round freely, because things like lichen sclerosis,
tell us things like this
because no one bloody talks about it. That's the thing. It's like everyone's in the dark. It's pretty common. I think it's something like 30% of women, even in their fertile years, will have adhesions. It's a pretty common thing. Just like guys, if they don't retract, it's got the most awful name, but smegma. It's the worst name, isn't it, in the world? And but eventually it can kind of stick, and then you can get a painful adhesion. And then if you do get aroused, you can get sharp pain in your clitoris. And because even as a doctor, I wasn't taught about that. But that becomes more problematic as you get into midlife and conditions like lichen.
Comes back to women's pleasure not being prioritised, and just like suck it up, just one more thing.
It's a historic sort of sociocultural religious thing that we're sort of and we consider all of this to be normal. But when you go back through the literature around it, there's a lot of roots in control really of women's bodies that underpins some of the norms that I don't think we think about in medicine, where they've come from, but a lot of them are that we preserve penetration above preserving the tissues of the vulva, which are where we might get our pleasure from.
There's a great chapter title in Sarah Graham's book called "Can you get a baby out and a penis in?"
Well, yeah, exactly.
Sums it up.
And and sadly is kind of where medicine's been at until more recently. So there's quite a few of us that are working in this field saying, can we just realize what we're doing here? I had a lady who was young who'd had gynae cancer and had radiotherapy where you can get scarring and the vagina can kind of stick. It can stick together, so you have to use dilators to keep it open afterwards. And she was only in her 20s or 30s. But she'd been given vaginal dilators and she'd had a cancer that had nothing to do with estrogen, and she'd had her ovaries fried by the radiotherapy and everything else. Nobody had given her vaginal estrogen. So there was this attitude that you must be able to be penetrated to keep you sexually active. We must do something routinely about that. But there was no conversation.
Wow.
And that's not deliberate. No one's sort of deliberately. It's just not in people's brains that this is important, and it needs to be.
So if anyone's listening to this and they're struggling, first port of call, I guess, to look at some of the resources that we'll put in the show notes, but to go and hopefully, have a good conversation with their GP. If they're not finding that that's kind of getting them somewhere, what's the sort of the next step for them?
So the resource that we're going to put in the BSSM consensus statement, I think, is really useful because it educates as well as giving all the evidence base. So hopefully that would get a lot of people over the wire in terms of getting the help they need. I think from a learning about sexuality, busting myths, and just what I would call psychoeducation, which is what we do a lot when we're treating people. There's some great books that are self-help things. So Mind the Gap by Karen Gurney is brilliant. Laurie Brotto's Better Sex Through Mindfulness it's not waffy, it is really sensible and really good, and it helps. So there's books like that, Becoming Clitorate by Laurie Mintz and things. So you can do quite a bit on your own and learn. from a HRT and other things you can do, because it's not all about HRT. I sometimes use daily tadalafil, which is a Viagra-like drug. I sometimes take people off things like antidepressants and antihistamines and blood pressure meds that are messing up their sexual response. Going to see a doctor that understands about sex can help, and there are some of us knocking around. So you can go through the IPM website, the Institute for Psychosexual Medicine website. It's got a list of practitioners. COSRT, which is COSRT, has a list of therapists. The British Society for Sexual Medicine, you can email and ask if there's a clinician working near you, and that would be a way of doing it. There's quite a lot of resources that are out on the internet that I've informed that there's something called Menopausal, which was a charity near me in Hull, and we did about 4 videos that are full of information that are free. There's an FSRH package that your doctor can go on to for 40 quid that's educational about sex and menopause, which is out there. So there's training that's available, but sadly you still sort of need somebody who knows about it. And gynaes don't always, and we're just not really taught routinely about it. So a referral to see somebody on the NHS would be great, but sometimes you might need to shop about a bit more.
Yeah, but don't suffer in silence and
Don't,
get
yeah.
fobbed off.
Yeah, absolutely. And a lot of it you can do on your own. I think the big message is, the biggest culprits for drugs are antidepressants. They dry you and they make climax much more difficult or impossible. So, if you're on one of those and you're struggling, that's something that you can talk to your GP about. If you're getting reduced sensation or urinary tract infections, that's something you can talk to your GP about. You can get vaginal estrogen, you can get prophylactic antibiotics to use after sex, just one after sex, and it helps, and that's in the NICE guidelines, and you can do that. So those things are easy to get hold of and make a huge difference. It's not all about testosterone, and people tend to. I do use quite a lot of testosterone, but I stop about 50% of the stuff that I start because it wasn't that was needed.
Yeah, actually, we haven't even touched on that, but we do have a great episode with Dr. Katie Barber on testosterone. Yeah. So if you're listening and you're thinking, I've been hearing lots about testosterone, I definitely recommend going back through the archive and finding that one, because she really does go into a lot of detail.
From a sex perspective, I see it as a baseline. If I'm going to treat somebody who wants to have HRT, I would get them on the correct dose of estrogen, not just some, but actually make sure they have enough. And I would try them on testosterone and see if it helps. And I'd give them 6 months of using testosterone before we gave up on that. But often in the work that I do, that's like level 1 of what needs to be done. Then a lot of it is about the brain stuff and the relationship stuff and the other bits that can sometimes impact libido and sex.
Well, so when you say enough estrogen, how do you know?
Am I allowed to swear? Because I think people stop at it not being shit on a regular basis. Women are in such misery when they come and see us that the fact, as soon as it's not as bad as it was, often they kind of go, that'll do. And also there's a lot of residual fear that they're going to give themselves breast cancer and be to blame forever for that. That's how I think people feel for wanting to feel better. There's that kind of guilt that they carry. So I see lots of women that sort of have a bit and go, oh, I shouldn't really be on this stuff anyway, but I am, but it's not that bad. And that if you're still having flushes, if you're still achy, if you've still got vaginal dryness, if you've still got dry skin, you need to titrate up to the level where those things have improved. That doesn't mean I think you should shoot up onto double, triple above the recommended limits. I think you should stick to licenses. And if it's not working when you get to the top of the licensed drug range, we normally switch you to a different product or check that you're absorbing. But probably 15% of women on stuff that goes through the skin don't absorb brilliantly, and they'll be walking around thinking this is as good as it gets, but it could be better.
Yeah, and actually they're not necessarily going to get a call back from their GP going, let's find out.
No, they're just mega busy. Yeah, absolutely.
And it's that whole squeaky wheel thing again. If you need to go and ask to have it reviewed.
Yeah, and not feel bad about that. I think again that I might be generalizing, but I think a lot of us are sort of schooled into being compliant and not annoying people, and and to some extent in this, I think it's really good to understand it's okay to self-advocate and to go back and say, actually, I'm still struggling with this. I still don't sleep through the night. I still don't feel like I've got myself back, because it often takes a bit of fidgeting and iterating to get it quite right.
Well, that seems like a fantastic place to wrap it up. Angela, thank you so much for taking the time to chat to us. You've certainly dropped a couple of things into the conversation there that I had definitely not heard about before. So thank you very much for taking the time to chat to us.
Oh, thank you for having me, Emma. It's been a pleasure.
You've been listening to the Middling Along podcast. Do remember to subscribe to be notified when our next episode is live. And why not visit the blog at www.middlingalong.com to sign up to my newsletter as well. I do hope you enjoyed listening today. If you did, I'd be really grateful if you would consider leaving a short review, as that helps people find the podcast and helps get it noticed. Hope you can join us next time. Goodbye for now.